Welcome, everyone, to our live chat. Today, we have a wonderful couple of guests that are going to talk about the telehealth, telecommuting thing that is leading the future of healthcare. And you're going to get an interesting deep dive into that. My name is Dennis Stearns, and we will also be taking your questions as we go. You have a couple of different ways to do that via Zoom, including raising your hand or using the chat feature. So let me introduce our special guests today. And in these sessions, we try to find interesting people doing interesting things for interesting times. Today, I think we've got a trifecta for those three. And so first we have John Nackel. And John, his previous life, he was global managing director of Ernst & Young's healthcare business and managed their venture capital fund. He has a master's in public health, a PhD in industrial engineering, and today he is the founder of Wavemaker 360, healthcare venture fund that invests in early stage healthcare companies. Welcome, John.
Pleasure.
And then we also have Dan Herbstman, and Dan has a equally interesting biography and lots of interesting background. For the last 10 years, prior to founding Third Eye Health, he was the senior director at a leading medical technology company in blood management, and today has developed what I think you'll find is a very interesting telemedicine application. Welcome, Dan.
Great, thanks, Dennis. Excited to be here.
So, John, I'm going to kick it off with you. Tell us about telehealth.
So I'm going to start with examples. I always find that it's easier to describe something with a story. So think of the farmer in the middle of Kansas. That farmer has a medical episode, has to drive to KU Medical Center, 300 miles away, literally takes a day to and from, loses his whole day of farming, and may get there and find out it wasn't even anything that bad, or may get there and need to be admitted to the hospital. So the whole concept of telehealth is to connect the provider with the patient and do it in a less costly, more efficient way. Now, I use the example of the farmer in the middle of Kansas, but the fact of the matter is the biggest telehealth applications are actually in inner cities. So I live here in Los Angeles. If you go to South Los Angeles area, you can drive for 100 blocks in each direction and not find a primary care physician. So the ability for an area of a town to have some kind of a clinic with a care manager of some sort, a nurse, maybe it's a physician assistant connected to, maybe it's USC Medical Center or UCLA, maybe it's just a community hospital. But the idea of connecting that local, close to the patient type environment with a physician is the key to telehealth. So that's the model. So why is it taking so long to develop this model? If you think about iPads and various types of telecommunication video type capabilities, we've had it for a long time. This is not new. What's kept us away from healthcare is two things. Number one is the professional societies, particularly physicians. In 14 states, telemedicine was actually not legal until 2 years ago. The state of Texas, the Texas Medical Association, fought telemedicine for many years. So many different states that was the case, and so it wasn't legal on a statewide basis. The second and more compelling reason, and the reason it's been so long since technology been around and still haven't been able to use it, is fraud. The Medicare program and the payers look at telemedicine as too ripe for fraud. You have a patient and a physician. We don't know if that communication actually did happen. And as you multiply the number of these times the potential for billing for Medicare, it became a real serious issue for them. And so most of the payers have not been willing to pay for telemedicine. So that brings us to what's changed. So what's changed is what's called value-based care. So over the last few years and the next 10 years, the industry is moving from fee-for-service healthcare to value-based care. Fee-for-service, you got paid for something. You got paid for a day of stay in a hospital. You got paid for a surgery, hip surgery or heart surgery, transplant surgery, whatever it might be. You get paid a flat amount for serving that particular physician service or hospital service. Under value-based care, the payers will pay a per member per month. So they cover a population. That population is expected to be cared for by whoever's covering that patient. And in some cases, it's a physician organization that will cover them. And in some cases, it's a hospital organization. And in some cases, it's a payer or some combination of the three. So under value-based care, now the incentive is to keep the patient out of the hospital. The biggest costs are the hospital-based services, the acute care. So now if you can do some kind of preventive service, there's a reason to keep the patient out. If there's some type of service that farmer in central Kansas has an opportunity to connect by phone, you would much prefer to do that and get a diagnosis and maybe have to go into the hospital, but 1 out of 20 times, 1 out of 100 times, whatever the number might be, way less than making that round trip for 6 hours.
Yeah, John, let me jump in here with a question.
Sure.
One of the clients who was the president of the American Hospital Association mentioned this some years ago, this concept of we'd like to keep people out of hospitals, and that probably seems kind of odd to people, why hospitals would want to keep people out of hospitals. Can you elaborate on that?
Yeah, it's a couple reasons for that. One is hospitals now are more than inpatient facilities. They tend to be the full spectrum of healthcare. So they often own their physician groups. They often have ambulatory surgery, ambulatory care. And many of them, they have long-term care facilities, assisted living type facilities. So they're more of a health system rather than a hospital system, acute care. The other reason is several of them have taken that risk on. So they are in essence, the insurance company for that population of patients. So now they look more like a payer in terms of wanting to keep the patient out of the hospital. So a number of reasons, but basically those are the two major ones.
Okay, and I know you're going to get to it in terms of the pros and cons for any of our physicians who are watching.
Sure. So what's the value proposition here? So as I said, the value proposition for the insurer is they're able to predict their total costs rather than not knowing at the beginning of the year what it's going to cost. If they're paying a per member per month rate, they can take their patients, multiply it by that rate, and they know what their costs are for the year. The organization that's most concerned about that one is our government. So the program that you may have heard of is called Medicare Advantage. And under the Medicare Advantage program, the patients are covered under a per member per month type basis, and therefore it's more predictable. this is the biggest growing program in the Medicare marketplace. So Medicare Advantage, and the reason people sign up for Medicare Advantage is they tend to have a lower copayment and therefore less out-of-pocket expense. What they give up for that usually is access to 100% of the docs out there in the hospitals. So there may be some limitations on who they can go see and where they can be admitted. For the provider, think about the provider now under COVID. You have a physician that can now see a patient, does not have to physically see that patient, can do this from an office or from home. And Dan is going to describe exactly that for Third Eye Health in a few minutes. But these physicians are able to see more patients. They can see them in a safer environment. And there are many things that need to be done face-to-face, but a lot of what medicine is all about can be done with good record keeping and devices. There now are far more devices out there, so people have home heart monitors, have home blood pressure monitors, have temperatures, have an Apple Watch with 3 or 4 on them. So part of this is the interface with technology is driving the provider side. Then on the patient side, again, if you're a COVID, in this COVID environment right now, you're a patient with something not related to COVID. So you have some minor problem and you are going to go in and see your physician. Well, you don't really want to go into your physician office right now. And if that physician can see you by telehealth, the advantages to that patient is they're not going to get that infection and they're not going to be susceptible to whatever else is going around in that physician office. So, or hospital, if it was a hospital kind of example that I used. So let's talk about the impact of COVID. COVID's had a huge impact on telehealth. Telehealth was known before COVID, but it now is a major reason for the future success of telehealth. The COVID environment for the because of the environment between the provider and the patient, there's so much more reason to do this by telehealth. You've got the opportunity to see more patients. You've got the opportunity to keep providers, nurses, all different types of healthcare givers, the opportunity to not get infected with the COVID virus. So the other thing that's driven it is under the relief program from Medicare, they're allowing telehealth to be billed. So where previously a lot of telehealth was not billable, now it is. So this is a huge environment change for telehealth. We have in our portfolio in Wavemaker 360 several telehealth companies. And Dennis, I'll let you introduce Dan, but Dan will give us an example of a telehealth company, particularly in this case in the skilled nursing environment. Thanks for allowing me to join your group.
Yeah, thank you very much, John. And for our audience, John had a computer problem a few hours ago, and as everybody has had to do here in this environment, has had to be innovative and creative. So he's doing this from his phone. So thank you, John.
Happy to do it.
Yeah. And so now let's get to you, Dan, because you are knee deep, waist deep, probably nose deep in this telemedicine. Just walk us through how you got started, what you're doing.
Oh, absolutely. Yeah. Deeper than you could imagine, Dennis. It's been a crazy, crazy time for us. But yeah, if we want to go ahead to the next slide, that would be great. Perfect. And to give you guys a little background, I'm the CEO and co-founder of Third Eye Health, and we've been almost laser focused on post-acute care, meaning we're providing telehealth to nursing homes. And we have really two major goals in helping the nursing homes. One has been to help them reduce their transfers back to the hospital, and also allow them to take in higher acuity patients and give them both the clinical and care coordination support they need to do that. And as John was talking about, the big reason that nursing homes want to do that today are, if they can treat a patient in place, it's so much better for the patient clinically. Many times if they have to go back to the hospital from a nursing home, they'll come back much sicker many times. They can pick up infections, other things there. And on the economic side, hospitals are penalized, as are nursing homes, for sending patients back within the first 30 days of getting to nursing homes. So they're really working to avoid those regulatory penalties. And then there's some interesting economics for the nursing home, that when they send a patient off and it's not a necessary reason, they can lose a fair amount of money per patient, because they have to hold that patient's bed, but they can't get any reimbursement from Medicare, Medicaid, or the other payer for that patient. So under the current system, they have an incentive that if they can treat the patient in place, they would do that. And so they brought us in to help with that in a lot of ways. And the way to think about us is, we're both a telehealth technology company. We've created a telehealth technology that took sort of everything good about telemedicine that was used in hospitals through these traditional larger cart-based solutions, and we put everything onto an iPad. And then on the other side, we have our own physician practice. So we have about 120 emergency medicine physicians, hospitalist physicians, who can really treat acute issues. So really what we're offering the nursing home is the ability to bring the emergency room right to the patient. So with a nurse walking into a patient's room, they can bring in a tablet using our software. They can connect remotely with a ER physician who has everything that they need to really be able to treat that patient in place. And what we've shown them over time is a real ability to reduce the need to go to hospitals by a pretty significant amount. And just as background, we've been around since about 2014. We've been growing about 2.5 times a year, really, since 2016, as we kind of found the product and the market fit for what we're doing. And you'll see John's company's logo on there, Wavemaker 360. We did a Series A investment round about 18 months ago, and we had some really good players that were good venture capital groups that understood healthcare really well, along with a couple of those names are owners of senior housing, real estate, and operations groups. So they really saw the value of what we were doing also. And I'll just jump to the next slide. Yeah, and to give you guys a sense of where we are today, we're in 30 states, and we have about 1,000 nursing homes. I'll talk a little bit about this in a second, but pre-COVID-19, we were the largest player in the market for telehealth to the skilled nursing homes, and we had a little bit under 400 nursing homes implemented. And now, just over the last few weeks, a lot of our current customers have come back to us that represent a lot of the large nursing home chains, like a Genesis or a Consulate, or a couple big customers that have national chains, a lot of big regional chains. And they've really given us all of their facilities. I can talk about a little bit why in a second, but it's been crazy growth, as it's been much more difficult for providers to get into nursing homes. If we could go to the next slide.
Yeah. Actually, before we go to the next slide,
Yeah, absolutely.
Before we go to the next slide, Dan, could you explain what it meant on the previous slide, the last mile connections?
Yeah, it's been so interesting to us. So we've created a technology that's now in the most nursing homes in the country. We think we'll get to probably about 2,000 nursing homes by the year end. And mostly what our customers used to want from us was our technology, so they could access our doctor, they could reach them in 2 minutes, they could do that quick ER consult. Now what we're seeing is it's so much harder for the primary care physicians and specialists to come into nursing homes. Also, because of the Medicare changes, they can now bill for their visits, which they couldn't before through telehealth. So we almost become this last connection into the nursing home that so many providers who want to get there, our technology platform and our implementation process is now the best way for them to get in, so that our technology matches the nursing home nurse workflow. And so now when I say last mile connection, it's all those outside provider groups, primary care and others, are really leveraging us to go in and be able to do their patient visits in these 1,000 nursing homes and growing. It's changed our business. Good.
Yeah. So, and could you also explain what the different colors are on this map?
Oh, sure. Yeah, I probably should have put up a legend there also, but that represents different nursing home chains that are using us. So what we found is it's really the larger national chains and regional chains that are starting to use us. They're part of the nursing homes are part of those groups, and so it's hard to tell from this map, but we actually have about 50 distinct nursing home chains that are leveraging us right now across a lot of their facility footprint.
And I think it's fascinating based on what John told us a little bit ago. If you look at Texas, you have a lot of things going on in Texas.
A lot of things going on in Texas. Yeah. What's so interesting to us when we put this on a map was that we've been actually focused in a different way than we thought we would initially be focused more in rural areas. It's actually, we've been in mostly the metro areas that you can see in Texas and some of Illinois and Midwest. We're in some rural areas, but it's really been those like urban, suburban nursing homes that are really closely aligned with the health systems that John was talking about and really part of their extended networks, because they're trying so hard to manage patients in the lowest cost place possible. They're all working really hard together, the nursing home chains and the hospitals, to manage those patients in the nursing home, manage those patients in the skilled nursing home rather than send them to the hospital unless they absolutely have to.
Okay, well, and we do have one question that I'll throw up here. So why did you choose to focus on nursing homes versus other medical facilities?
Yeah, it was interesting. We saw a real opportunity where we always hear that telehealth is kind of a noisy area. There's lots of groups doing it. There's some great groups, I think, in like I'll say a Teledoc or an American Well, that have done a great job in focusing in starting with consumers through insurance plans, and then also moving to health systems. That we started off in a slightly different area of telehealth, but as we started to look at the opportunities, we saw one area that was just completely underserved was nursing homes. And so we went in now it's about 3.5 years ago, and started with our first nursing homes, and we were really kind of one of the very early players there. And it was before all the different incentives that have happened in the market around reimbursement, other things caught up. And so we've been kind of actively growing this, I would say, niche market, with the idea that 2 to 3 years from now, it might become of a more mainstream market. And then, as we all know, what happened overnight is COVID-19 happened, and telehealth, we feel like telehealth, and talking with John too, it's jumped ahead 5 years from where we thought it would be. And what we're doing was an early adopter sort of market has now really become every nursing home feels like they need to have a solution. It's not just the larger nursing homes that are working with health systems that need to keep patients out of hospitals. It's really everybody. And so we've suddenly gone from early adopter to mainstream very quickly.
We had a discussion in our live chat this morning that's usually around more economics and investing, that they've talked about 10 years of innovation in 10 months. So clearly some things are sprinting ahead here. Bill, why don't we go to the next slide?
Yeah, and I wanted to show everyone what the technology looks like and what our solution really is. So this is just how our technology looks, and so we've tried to make it incredibly easy to use for the nurses in the nursing home. So when we see that, that's a primary user of our technology. So in the past, most telehealth has barely been delivered through mobile carts that had a lot of medical devices, other peripherals. We've kind of really taken all of that and put it just onto a tablet, with the idea that we have a stethoscope that goes with this, also an EKG if they want it. And then we've integrated with all the different nursing home electronic health record systems, so that really what the nurse does, and if you guys want to go to the next slide for a second, is really just taps one button, and then our technology can be used by the full group. And so when we see everything today, how everything is used in a nursing home, is that technology you just saw is at every nursing station in a nursing home. It's can be used on any tablet. We like to use iPad minis, but it could be anything else. And then all the daytime providers or others who come in, all the daytime providers or others who are trying to access their patients can have a nurse reach out to them. Our physician team usually comes in on nights and weekends to handle emergencies when there's the least amount of doctors available, or can be backup during the day to the doctors who come in. And then we built out a care coordination team and model that also also has a nurse on our team who works through our technology to hand off patients between the two groups, between the day and the night staff, to make sure that no patients get lost and everyone understands exactly what happened. And that's been a big issue kind of we've helped solve, and in the care being not lost among the groups.
Yeah, Dan, we have a question from our audience that I think I might know your answer to, but so what about the vastly larger number of people who aren't in nursing homes but are at home? Is your technology adaptable to that, or are there other entities that are tackling that market?
Yeah, we actually think that that's a real market that we could go after in a big way. The home market, we don't think anyone is really effectively going after it. It was interesting because because there was no reimbursement for telehealth. We had to find the first use case or first group, and it was really the nursing home, because just using our technology, even without reimbursement, they would see such a strong return on investment by helping keep a patient in the bed. It was that example I described, that when a patient goes away, they lose those bed days for that patient. So this was our first market just because of this. Now we see this opportunity to really grow from the 1,000 nursing homes we're in today to hopefully all 15,000. And at the same time, we think so many patients go directly to home. They're going to avoid the nursing home wherever possible, especially with how much there's been around nursing homes with COVID-19 and everything. So we see that as a future market, and really we think it's almost like an untapped area. There's a few players that are working in there, but it's very, very early.
Okay, great.
Great. If we go ahead to the next slide. And so just to bring up COVID-19, and John mentioned this too, we see this as almost the sentinel event that's moved telehealth forward. As you said, 10 years of innovation in 10 weeks probably is a way to think about it. But really that imperative that we saw before, which was what I described around not transferring patients out of the nursing home to the hospital, made a lot of sense before. Now it's become a whole nother level, kind of like John was saying, that it's so difficult for providers to come into nursing homes. They've adopted telehealth in a big way. And because we're that platform in the nursing homes, a lot of the primary care doctors have adopted us. And we both John and I mentioned it, but now Medicare is reimbursing for telehealth. So now that providers are able to bill the same in-person rates they could for in person as they can for this. And as we talk to other experts and other things that around whether these changes may be temporary or permanent, it just seems like now that telehealth has gotten where it is, it's going to be hard to really go back. And we see Medicare probably keeping the ability to have all these visits, and if anything, probably continue to expand that.
Well, and that is a interesting question that our audience has posed in a couple of different ways. What are the other applications that are out there that are possible?
Yeah, for telehealth, or for telehealth in the nursing home, or just kind of broadly, you're
Well,
thinking of?
just broadly.
Yeah, it's exciting. Like you were saying, we think telehealth can be everywhere. It's really we've created this sort of early niche case that's becoming more mainstream in the nursing home. For our own company, we see ourselves going into sort of everything outside of the hospital. We think that the hospital side of telehealth, which is usually more about bringing specialist care to hospitals who aren't able to have those specialists, to bring all sorts of different types of doctors to rural hospitals. We feel like that's one that's probably most advanced of everything. But where things are kind of wide open are really the market we're in, the sort of senior living market and the home market, where we think, especially for these sicker patients, they'll be managed much more at home or in their home environment, and we can bring telehealth to really all of those different areas. We also think incorporating some different types of technology and artificial intelligence into what we're doing can really help advance what we're doing. And just to give you guys a sense of how our trajectory sort of changed as a business, as I know you guys are looking at that, we become basically the combination of the technology of choice that goes into these nursing homes and also providing mission critical service. So we thought the last couple of years, we've grown about 2.5 times a year in terms of revenue and growth. And so we thought this year we would end with about 650 skilled nursing facilities and be a little bit over an $11 million business on a recurring basis. What's happened this year after COVID is really all of our existing customers and a lot of new ones reached out to us and have wanted to expand what we're doing greatly. And so now we see ourselves in a whole different light, being growing to almost 1,200 SNFs this year, potentially as many as 2,000, and really becoming more like a 15 to almost over $20 million run rate type business in the year.
Yeah, so another question, and this could be for you, Dan, because I know you're HIPAA compliant, but also John, is what's been done to deal with the fraud issue that you talked about earlier?
Dan, why don't you start and I'll jump on.
Yeah, no, absolutely. Yeah, so we've worked really hard in making just our technology secure from the HIPAA compliance side and kind of gone beyond that to what a lot of health systems require in SOC 2 compliance. So kind of have dealt with that for security and everything. But and then as we think about medical visits and everything, what we're looking at is really the key here is showing medical necessity for these visits and really being able to show that these consultations are required. One thing that worries me always is fraud in this space, because we think of more and more people like starting to build telehealth or doing stuff because this opens. But I think of that as sort of the slippery slope or smaller group of folks. And really what I think this does more than anything else is just catches up the world with sort of how we're all getting on Zoom to do things and see each other now. I think telehealth is really something that's been, should have been around for a while, and is finally here, in that and then now people are able to deliver care that could be delivered through video, through other telehealth methods. And now, rather than going in person, just because it was the way of doing things before, we now see this in a bigger way. So I think any small potential for fraud in doing these visits are probably outweighed by the ability to bring telehealth and care to a much greater group of people in the place that's least costly for them and most clinically appropriate.
Yeah, so let me jump on that. I think the other part of that question, Dan, really is about how does the payer know that the service was actually performed? It's less of a HIPAA or a patient information issue than it is a concurrence that the event happened. And I think that will be solved through signatures, electronic signatures, digital signature kinds of technology. And I believe that's going to be fairly straightforward to solve that problem. Then the question is the medical necessity. And I think you're going to find that the medical necessity will prove its case fairly quickly. And I'm going to give you an example of a non-physician. Dan's focused on the physician side, but some of the companies we're seeing in telehealth are equally effective using nurse practitioners and case managers. So, for example, for a patient that has multiple chronic illnesses, a lot of what they need to do is take their medicines on time, comply with the various doctors' treatments, and the care manager, the case manager, often their role on telehealth is just to remind and to reinforce the formal medical treatment plan. And in the cases of multiple chronic diseases, these are patients that end up in the emergency room 2 and 3 times, sometimes as many as 10 times a year. You think about those visits, an ambulance and a emergency room visit, the total cost for 10 visits in a year is in excess of $100,000. So if you can get that patient to comply with their medicines, comply with their treatment regime, and has a regular once a week call with a caregiver or case manager, that cost is so incredibly high in terms of return on investment. So I think that they're going to find out that the value proposition is pretty strong here. And then the fraud side, I think, will be solved with digital signatures and other types of encryption type capabilities.
Okay, very good. So Bill, let's go to the next slide.
Yeah, and then I'll just cover the slide in a minute and then love to open it up for more questions. But
Mhm.
we've created sort of a unique nursing home care service, and we've sort of purpose built what we're doing for the nursing home from a technical perspective, a care model perspective, and then how we implement. We've also been able to get a lot of health systems, especially in the Chicago area. We call it our Chicago model. That's our home area, to really endorse us so that they're mandating that any of their skilled nursing partners need to use us. And then we've created this strategy in the near term of really becoming a telehealth platform so that other provider groups who want to have access to the nursing home can really use our technology to do it. We see the ability to expand that over time. We have a whole set of new services like palliative care, pain management that we're going to begin offering through our platform on our own. And then, as I mentioned earlier, through some of the questions, we're going to expand what we're doing to really also move to the home health area, the assisted living area, and then down the road, we're looking at some ways to start to enter into contracts more with the payers around some of the value-based areas that John was talking about a little bit at the beginning, to enter risk-based contracts where we take care of populations of patients and are kind of incented to treat them with high clinical quality metrics and as in the least costly way as possible.
Yeah, very good. Well, you've done an amazing job, Dan, and I am sure that you're going to be one of those we want to watch in the future. I mean, who would have guessed 10 years ago that we would have something we could wear on our wrist that was an FDA approved EKG machine in the Apple Watch? And so if Tim Cook were part of this program, what would you both tell him that we should do more of in the future, other than just more telehealth? Because I know that his end game is that everybody, that this be ubiquitous across our entire culture, right?
Well, I've already seen that in terms of the integration now with technology. Wearables has become another big area, and telehealth and wearables are going to overlap dramatically. So as we get more wearables, the problem with wearables right now is there's hundreds of them, and everybody claims, well, you can get information to your doctor directly. Well, the fact of the matter is doctors aren't looking at that stuff. If they were to do that for every patient that's in their population health that they manage, they wouldn't be able to do it. So it's got to be done with some kind of other analytics. So I think it's the combination of wearables, telehealth, and analytics that is going to drive the opportunity longer term. Dan, what's your thoughts on that?
No, I agree. I think simplicity is always been interesting to me, and almost taking that analytics to the next level of saying what we would love in our business or just broadly is to be able to get very simple alerts that are meaningful about patients, that are not sort of false positive in nature, but really allow just in our use case a doctor to act on things in a better way. We're always looking for ways to identify earlier those risks. And if I could talk to Tim Cook, I'd ask him to get more FDA approvals on, I think, some of the metrics that they have, and also put a lot of data behind ways to make it simple for doctors to use.
Very good. Interesting note, one of our clients who is in a continuing care retirement community in Cary, North Carolina, recently had some things done to her leg and a hip replacement, and a lot of her physical therapy was done in her living room. And the healthcare system wheeled in a video screen and variety of other technology, and there was the physical therapist on the screen working her through things every single day. So a lot of different interesting applications that I think we'll see in the next 10 years.
Dennis, I see a question there about how 360 is doing, Wavemaker 360. Just a couple comments I'd like to add on that.
Sure.
First of all, our portfolio, which had no intention of, we had no knowledge of COVID when we started investing in companies, but as it turns out, well over half of our companies actually have a better message today than they did 6 weeks ago. So I'll give you a couple examples. The telehealth ones you already know, and you can appreciate that from our conversation here. But we've got a lot of marketplace type products. So matching a PT, a physical therapist, as the one that you just mentioned, with a patient that needs physical therapy. Would you rather go into a physical therapy site, or would you rather have the PT come to your house? Well, this matches that up. Most people would much rather have the PT come to their house and not take the risk of 20 other people that they're going to run into from some kind of other disease. And so that matching type technology is a big opportunity. Another one that real hot with respect to COVID is mental health. So a lot of people, like almost everybody on this phone today, is at home, and you've been at home for 5 weeks. Well, if you have to do it another 6 or 8 weeks, we're going to have people bouncing off walls. Well, we got.
You already do.
I believe that's the case. So one of our companies is a matchmaker again that matches psychiatrists and psychologists to patients that need therapy, and all the way to the point where they bill it and collect it and return the money to the therapist and handle all the billing component of it. This was a nice to have pre-COVID. In COVID world, they're really doing outstanding right now. So a lot of these matching type businesses have been very strong under COVID, as has a lot of the data analytics companies. One I'll give you an example of is a lab company. So we have a lab reporting company. Well, they know 20% of all the COVID patients in the whole country right now. So you think about the knowledge they have about where the hot spots are and what the issues are. They have more knowledge about COVID cases than any lab company in the country, even though they're not a lab company. So the Quests of the world that may manage about 20% of the lab market, they don't have any more data than this company does. So data analytics is another area that the fund has done really well in. So we're pleased with our portfolio and very pleased with Dan and Third Eye Health. Third Eye Health has been a phenomenal company and doing good things for healthcare. That's always been our mantra, is that we're interested in companies that really do good things for healthcare, but at the same time, we like to make money.
Yeah, very good. Well, and I know a number of our audience are investors via the partnership between Stearns Financial and Wavemaker 360, and we are very happy with what you have been doing, and also the great intelligence data that we get provided with. There was one other question that I thought was kind of interesting around the adoption, and I know we're early days here to a certain extent, but the adoption by different age groups, maybe different demographic groups. I mean, Dan, can you talk about at least so far who has been more open and excited about this area?
Yeah, I think, one of our worries in the space we're in, where most people are over 65, is that we would have low adoption or patients refusing to use our technology. What we experienced is sometimes a tiny bit of skepticism, but everyone who's had we've rarely, if ever, had any patient refuse to use our technology, and they have the ability, of course, to give their own consent and everything. And nurses will work with them on that. And it's been very exciting to see the feedback we've gotten, and we've done a lot of satisfaction work with patients who've used our technology, their loved ones, also nursing staff, and it's been pretty good across the board. It's almost like as soon as someone gets experience with it, that they're able to they really embrace it. And so we've had this just great set of data in the above 65 population, and with huge acceptance and huge satisfaction. And when they think of the alternative, which is going to the hospital rather than using our technology, it's been just great to see some of that some of that from our own anecdotal examples.
Yeah, and John, do you have anything to add on that?
No, I think the adoption is going to go up very rapidly. First of all, it's if you think about almost everybody under 40 has grown up in a world where they've had smartphones at least at some point in their last 20 years. Kids, the millennial level, have only been raised in a smartphone world. And then most of us have adapted to the technologies. And, you think about older people, well, they still see their grandkids by FaceTime. They still are connected to families that don't live near them using tele services, whether it be FaceTime or Zoom or whatever it might be. So I think adoption is going to happen very, very quickly. I don't see that as a significant issue for the industry.
Yeah, very good. So John, do you want to tackle this question we got from our audience about a telemed company called Hilo, I think it is?
I don't know. I've never heard of that one, so I can't answer. I don't know if Dan or Jay, have you had any experience with them?
No, I don't know them either. No, I was just looking them up in real time actually to see if there was anything available. I've seen them, yeah.
Okay. The other comment I'll make, Dennis, on this is there are literally over 1,000 telehealth companies now. So this was a nascent industry 5 years ago. 20 years ago, when the technology was around, healthcare did not adopt, as I said, because of fraud and because of no payment. But in the last 5 years, as that's loosened up, there's been dozens of companies, and then literally in the last year, tripled and quadrupled the number. So I don't know Hilo, but I can tell you there are dozens of these. I think you'll see a roll-up of these companies at some point. So people that are in specialty areas, maybe you combine a few of the specialties. Those that are associated with primary care medicine, there might be a roll-up of those. Teledoc's an example of kind of a roll-up. There's been a number of companies they've bought as they've grown. So I think this is a sector that's very prone to being rolled up just because of the sheer number. And by the way, half of those will go away, or maybe 3/4 of those just won't make it. And there's anybody with a shingle and an LLC can start a telehealth company, and a few of them probably have been formed just in the last 5 weeks.
Yeah, well, that just reminded me of actually where you are, John, in LA, and south of there down to San Diego, and the whole biotechnology boom. And very similar thing happened. There were a lot of players, a lot of entrants, and there were only a few that became Biogen or Genentech.
Yeah.
Yeah. All right. Very good. Dan, any closing comments you'd like to share with our audience?
Yeah, no, I wanted to thank everyone for having me on the call. I appreciate it. And no, it's been sort of one of the biggest things that's happened in our world, but sort of the telehealth world in general has just been, I think, COVID-19 really brought things ahead a few years, 2 to 5 years, as I think about it or talk to people where this market is. And it's just sort of hard to imagine going back now, as all of us are doing this call on Zoom. And I went to a Passover Seder this week on Zoom and other things like that. It feels like that's become mainstream. And if I know if my parents were able to get onto that Seder, telehealth is really here to stay if it's that easy to get onto a video without too much explanation.
Yeah, very good. And John, it looks like you've gotten outside into the beautiful outdoors.
I wish I could get out there more often. It's been raining here. The last 3 days it finally got the sun out, but we had like about 2 straight weeks of rain here. So, and I haven't been able to get the golf clubs out because all the golf courses are closed up. So, but Dennis, I want to thank you for inviting us. I would say that the future of healthcare is changed dramatically in the last 5 weeks. I think people that never heard the terms are now thinking about health, and by the way, they should have been thinking about it a long time ago, because there isn't anything more valuable in life than good health.
That has been our mantra right along, that it's the number one asset, but it seems to be the asset that people don't always take care of like it was their number one asset.
Yeah.
Yep. All right, John, Dan, thank you so much for being with us, and thank all of you who tuned in. This session has been recorded, and as usual, early next week, you will get the ability to watch that recording again or share it with friends or others. Thank you all, and hope everyone has a wonderful weekend.